So we have an excellent sessions. We'll begin with first on the insulin session. This is one of the oration. So this is Dr. V.K. Agarwal, in the memory of Dr. V.K. Agarwal sir. This oration is first time kept in IMA CGP, and to deliver it, we have amongst us Padma Professor Tripathi sir, who is a nephrologist and a former professor at the head of the Department of Medicine, BHU, and he would be deliberating his talk on barriers in initiation of insulin.
We will begin today's session with the prestigious oration dedicated to the loving memory of late Professor Dr. V.K. Agarwal sir, a legendary pediatrician, a brilliant clinician who headed and shaped the Department of Pediatrics, Eminent Medical College, Allahabad. Much loved, always respected, and deeply remembered. I will request Professor V.K. Agarwal sir's family to please come to pay their floral tributes. Mrs. V.K. Agarwal ma'am, Dr. Sanjeev Agarwal, Dr. Kavita Agarwal, Dr. Vikram Agarwal, Dr. Anuradha Agarwal, Janvi, President Dr. Sujit Singh and Secretary Dr. Ashutosh Gupta are also requested to please accompany them. I will now call on the stage Dr. Anil Shukla sir to please introduce the oration to the audience. I will also request all the respected chairpersons for this session to please take seat on the dais. Dr. Anil Shukla sir, Dr. Anil Agarwal sir, Senior Practicing Physician of repute and renown, Dr. Atul Madhav, Senior Practicing Physician and founder of many organizations of Allahabad, both scientific and cultural, and Dr. Saurabh Gujarati sir, Senior Nephrologist of the city, reputed and renowned of the city. The ongoing pictures are a little clip and a little peek into personality of Professor V.K. Agarwal sir. And we have with us Dr. Sanjeev and Dr. Vikram and Dr. Kavita and Dr. Anuradha, who are carrying forward the legacy of Professor V.K. Agarwal sir. I will request our chairperson, Dr. Anil Shukla, past President IMA, to introduce the V.K. Agarwal oration to the gallery.
Thank you, Dr. Padma. It is my proud privilege to present before such an august gathering the life sketch of Professor V.K. Agarwal, in whose memory this oration is being held today. Many of us have had the good fortune of being taught by Professor V.K. Agarwal during our MBBS and postgraduate studies at MLN Medical College. And in many ways, his name was and is synonymous with the St. Children's Hospital, which was built and later flourished under his care. Professor V.K. Agarwal was born on 15th August 1932 at Allahabad. And after his early schooling from Allahabad, he did his MBBS from KGMC. He completed his MD from Allahabad and an MRCP from Edinburgh. He was examiner for several boards and was the recipient of the prestigious Hari Om Ashram Award in 1985. He was a teacher par excellence and will always be remembered fondly as the father of pediatrics in Allahabad and indeed in Uttar Pradesh, as it was solely due to his efforts that pediatrics came to be recognized as a specialty in its own right rather than it being a branch of medicine. He was greatly admired for his astute clinical sense and a keen sense of humor. His was a multifaceted personality and medicine was just a part of it. He was a keen gardener, an avid golf player, and was also actively involved in various social organizations like Rotary and Ramchandra Mission. After his retirement, he set up the Guru Kripa Jagrati Hospital and Agarwal Hospital, which are providing quality medical care to the needy. He is survived by his wife and life partner of 53 years, Srimati Sushila Agarwal, and his two sons, Dr. Sanjeev Agarwal and Dr. Vikram Agarwal. Dr. Sanjeev Agarwal is a well-known pediatrician, and his wife, Dr. Kavita Agarwal, is a well-known gynecologist of the city. Dr. Vikram Agarwal is a well-known surgeon, and his wife, Dr. Anuradha Agarwal, is a well-known dental surgeon. 3 of his 4 grandchildren, are already studying medicine and carrying forward his great legacy. It is in the memory of such a great person and pediatrician of our city that we dedicate this oration today. Thank you. I hand over the mic to my co-chairperson to introduce the speaker.
I will now request the esteemed speaker for this oration, Padma Shri Professor K.K. Tripathi Sahab, Professor and Head PHU, a legendary teacher par excellence, to please take stage.
Thank you, Anba. In this crowd there are many eminent physicians of the town Prayagraj. I know few. I know one ENT surgeon who is just sitting at the corner, looking so young, much younger than us. And his daughter, my daughter, was class fellow at undergraduate at IMA Medical College, Allahabad. So I am obliged for his hospitality, as and when we visited his house. And we had good days together. I know Professor V.K. Agrawal for a little short time when I was like Anuva and organizing exams, undergraduate exams in Banaras University. And it's true, those years, medicine was part of Department of Medicine. The pediatrics was part of Department of Medicine. Psychiatry was part of Department of Medicine. Dermatology, venereology was part of medicine. TB chest was the part of medicine. So as a young lecturer, we had a responsibility to select the cases from pediatric department. And I've seen Dr. V.K. Agrawal that time, because I was the main coordinator, and there would be 30 marks with me out of 300, so it's a good number of marks, because those years, Professor would remember that postage was decided on the basis of your undergraduate performance. And these 30 marks would have a lot of value. Out of that 30 marks, 10 marks would go to the pediatrics. So you can understand the importance of pediatrics. Prior to those era, before 1965, pediatrics was not a separate entity in medical curriculum. People would do with MD General Medicine, DCH. Maybe Lucknow started for the first time in this part of country. Calcutta started. Down south was there, but it was very few departments. So the generation of Professor V.K. Agrawal at that time, they did very hard work. Agra Medical College, Professor Dayal, all these were the stalwart who really worked very hard for the uplift of the pediatrics. And today now we have a pediatric cardiology, pediatric endocrinology, pediatric surgery, and the department has flourished as significance in the fraternity. I've been given the task of talking to you diabetes management in India and what's happening and how much future is to be shaped. I was listening the guest of honor here and feeling the heartbeat why general practitioners are being awarded this privilege. We in RSSDI, to which I belong as a part, I'm not by training endocrinologist, neither I'm a diabetologist, I'm a traditional old-time schoolmaster of medicine, in which I continue even today. But then we understand and realize that diabetes, the responsibility of the treating these patients falls on the shoulder of each and everybody. And I'm reminded of one of the experience at the Mount Sinai School of Medicine in New York. One of the professor of endocrinology, whose many chapters are there in the Australian clinics, for the first time I met him in Mount Sinai School of Medicine, and he was at that time professor of endocrinology and diabetology, doing exclusive diabetology. After 5 years I revisited, he was not there. He was there in a small chamber at the 5th Avenue. You know what the 5th Avenue means? It is one of the largest practitioners' pool in the New York. I asked, sir, you have been the professor of endocrinology. How come you are general practitioner? He said, no, I did a mistake in last 30 years by practicing only endocrinology. Now I realize what I'm gaining as a general practitioner. That the perception of a person who has taught and practiced endocrinology and now realizes how important is the general practitioner they are. Likewise, many of us treating our patient in our family, and we do not appreciate our responsibility in communication. One of the important job treating diabetes is the communicating from patient and the doctors. And this is the ground reality of diabetes management in India. It's very frightening. Frightening in the sense, though we have 8 to 10% prevalence of diabetes in this country, however, uncontrolled diabetes, this is the landmark study which was conducted with the help of RSSBI Shashank Joshi, the former president of API and RSSBI. We have a large chunk of the people, 4 out of 5 of type 2 diabetes mellitus patients have been accounted in this study, and they are not under control. Out of this whole population, less than 1 of the Indians who have established type 2 diabetes mellitus on insulin, and average A1C which insulin is started is 9.2%, and that's very painful. Reason being very simple. The pathogenesis of diabetes starts at least 10 to 15 years before you perceive for the first time in life on LIC test or insurance test or for some other reason that your blood sugar is high. Maybe fasting sugar is high. Maybe the postprandial is high. Already enough damage has been done to the vascular endothelium, to the basement membrane, to the cardiac myocyte, to the endoplasmic reticulum, and to the mitochondria. And therefore, the newer molecules which basic scientists are looking for these to correct these machineries which have gone wrong, which have gone erratic, in spite of controlling your blood sugar. The damage continues, and that would contribute in many unknowing problems. And with me, Dr. Pandya, was talking to him. Initially, we thought that if you get a silent MI, sudden cardiac death, probably it's the beta blocker which you are taking, which has somehow have not led the perception of your precordial pain or perspiration. Answer is no, you may not be. If the cardiac myocyte dysfunction is the electrical conductance, is the action potential, is the basement membrane irregularity, which is responsible for your death, and which probably hardly any one of us felt when we examine these patients clinically. And that's why somebody was talking before, that we are no more doctor, we are treating technician. No, you have to apply both. You are not only a technician, but you have to understand bit of basic science. The glycemic parameters at the age of diagnosis in India is close to 43 years, and that's very bad. We are looking at the all parameters there in closely respond to 2 to 3 of subjects, that is 66.7%. And if diagnosis is done less than 43 years with the start of diabetes. And we have lost significant productive age before we either got the perception that we have adapted and now the treatment should be started. But the overall baseline parameter, by the time when you diagnose them, HbA1c is at 8.1%, fasting sugar 142, postprandial 205, and the people whom I treat as a primary care physician, I worked after my superannuation, now this 7th year of my superannuation from the Institute of Medical Sciences. And I treat 99.9% patients from extreme poor village area. Can't afford to buy even 10 rupee worth medicine. Even if they go to the Jan Swasth Kendra, hardly they can afford some of these basic medicine. And these people walk in my house with the blood sugar of 400, 500, almost asymptomatic, came for altogether different reason, either burning feet or some numbness, and then it was realized that the patient had diabetes. How much damage we've already done? Neuropathy most frequently reported complication in spite of expected low prevalence, and 50% of the subjects at 21 have more than one CV. We call it cardiovascular equivalence. If you have a diabetes already, you have already either one coronary or one ventricular arrhythmia, or you are starting incipient cardiac failure. Its treatment inertia is because of the oral anti-diabetic drugs overuse. Is it the family members? Is it the doctors, the caregiver, the politician, the media? Media is playing a very important role. We know each and everyone is contributing in this poor quality of life. In about 1/3, 1/4 of the subjects received only oral anti-diabetic drugs, only one drug. Should have received either 2 or a combination. And insulin is used only 1/4. And this is important, and which is the real topic of what today I want to talk to you. This is the landmark trial on which I am quoting, that in spite of, we use 3 oral drugs, and now it's very easy for general practitioner to pick up. We have fixed dose combination, glimepiride, metformin, voglibos. And then we have 4th one, they are SGLT2 inhibitors. And then the patient goes, if I tell them, but HbA1c 10, that now this is the time we should go for insulin, he would go to another doctor, another professor, another corporate doctor, endocrinologist, and will cool him down. Now we have an oral GLP-RA, why don't you take that 10,000 worth of medicine for a month therapy? So keep on adding oral anti-diabetic drugs till either patient is exhausted, or a complication appears, or someone else gives him the suggestion from a corporate hospital. Now there are practitioners in our city, in our country, who would be charging 25,000 rupees for a single consultation and writing you that particular molecule. And therefore, this inertia comes partly on my side, partly on the patient. Patient doesn't want to take it. Give me another chance. अगली बार देख लेंगे, अभी मत लिखिए, क्या जरूरत है, 3 दिन बाद देख लेते हैं. So no one wants prick forever. Prick for few days, okay. Few insulin injection but to take insulin forever, that would be a different point. What shall be approached then in how we should refer this issue of once oral anti-diabetic drugs in controlled patient? A diagnosis 50% of beta cell are already exhausted. Now, this is a general statement, but a hardcore endocrinologist, I have Alankar in the crowd, and he wouldn't probably agree. DM endocrinology boys don't agree, because we know that the alpha cell is undergoing metamorphosis, going under change. And there may be time when alpha cell may take over the role of beta cell at the hour of crisis. Or some of very old drugs, tolbutamide. Professor Dr. Oja might have written during his time, Dr. Mittal would have written the prescription of diabetes, or Restinol. None of these younger generation knows about it. Some of the very old drugs now, by molecular biologists working at the methylation of the DNA and as epigenetics, could now transform these alpha cells into beta cells. But these are the basic science research. These are the information which will get on the net, and that could lead to misconception. But we understand today, 50% beta cell by the time of the diagnosis has been done with a single drug, maybe two drugs, already taking, yet not controlled. We have lost your 50% value of beta cell. And therefore, we need to prevent it, protect it, regenerate it, replenish it. And one of the issues which is related to progressive decline in beta cell function, which leads to a lot of glycemic deterioration, is the glucotoxicity. It's under the hibernation process of the metabolic hibernation of the mitochondria, which is not responding to EM pathway or the glycolysis, or they acting on the TCA cycle, producing a lot of other components from the TCA cycle, glutamic acid, and very toxic substances which should not have been produced. So over the complete irreversible insufficient, and this is the word which now we are using, is this diabetes could be reversed, it is a reversible disease, or in spite of reversibility, can with these newer technique, we can go to the delay the complication, or it can undergo remission. Now the best word which is being used for these beta cell exhausted entities, remission of diabetes. You take care of obesity, you go for bariatric surgery, you go for the genetic or beta cell replacement, you can now go under remission. Be sure, the moment this technique or the methodology or the newer molecule stop working, you may again go into excess remission. This is what happened in cancer cell biology, and we extract the same information of this cancer cell biology towards the diabetes molecular medicine. There is progressive decline, and we understand this is a very famous slide we have seen many times and again, where there is a we start metformin after 4 years, lifestyle modification, still wait. Professor Bajaj, Madam Bajaj, the former president of RSSDI, the former president of the Diabetic Association of India, the former president of the Endocrine Society of India, and the Wendy, lot of laurels. Thank you, Madam, for visiting. And she is one who taught and knows everything about diabetes and endocrinology. So what I'm talking little info, because by training, I'm a different person, but it's all the well wishes of Allah who gave me the chance. So the loss of beta cell function is associated with an inevitable glycemic deterioration. No beta cell, no insulin secretion, glucotoxicity, overactivity, alpha cell have gone down. Then you have a hormone which is called glucagon have come up, and all these are leading to deterioration. And 1/4 function of beta cells are present. An unfortunate story at that time when you really need insulin, for some reason you are not taking. There is a drought. There is war, like we had Russia war in the Ukraine. No food, no drug. If you do not have a beta cell reserve, how you are going to behave? So we have a subject in the textbook. We are in the second volume of the international textbook of diabetes. We have a chapter what we call disaster medicine. How to treat diabetes during disaster, during wartime. Yeah, and this is the important part where we refer to this issue. When you do not have neither oral drugs nor the insulin reserve, and you don't have your own beta cell at the of crisis, it would be a metabolic hazard. This we have seen and understand many times a bad metabolic memory or the legacy. So early insulin therapy overcomes beta cell exhaustion. It gives you rest. You do not have the money, beg, borrow, steal, have some money, try to look alternative way to generate the money. That's what exactly endocrinologists do. If you decrease your 1% HbA1c, then you have a lot of advantage. You decrease 21% death by any cause, 14% in myocardial infarction, and 37% in macrovascular disease, includes stroke, peripheral artery disease. So, what is to be done is that any reason, and we should be concerned about the inertia part, and this inertia is one of the issue which is on the part of physician, on the part of the patient, both, which we call them now health care professionals. And this is a patient barrier. The prick is one. You can demonstrate on your skin and tell the patient that okay, it is not so painful. Number two, hypoglycemia. Number three, patient also seen somebody dying at the age of 85 plus. He had a very bad renal function, gone all, had a very bad peripheral neuropathy, insulin was given and the patient suddenly died. And he thinks it is insulin is responsible for killing the patient. In spite of 400-500 sugar, he doesn't care for. So titration and algorithm, and then problem comes with the availability. So physician barriers are mainly the hypoglycemia, and all of us have felt it. And we advise them, we have our own way of calculating. General physicians, general practitioners, internists, and everybody has some method of calculating. Nurses, they calculate the nursing home, they have guidelines, and accordingly they start and they titrate the insulin. Unfortunately, if it is not monitored properly, there could be few episodes of hypoglycemia. Maybe underlying metabolic condition, maybe beginning of the nephropathy, maybe patient has vomited, maybe patient has a bad GI, patient has a thyrotoxic disease, patient has comorbid conditions which could have added to hypoglycemia. Still, blame goes to insulin. So we have to be aware of hypoglycemia, and then this is more with the primary care physician, with the endocrinologist super specialist. Can basal insulin address the barriers? And this is why this lecture is important to general practitioners, to internists, that we can initiate insulin, and then there are evidences from the real world setting that insulin naive patient, even you start at the beginning, there's significant reduction over the period. So with the baseline from 7.7% HbA1c to from 8.7%, larger is the HbA1c, better is the reduction. And that has been pursued all over, whether it is oral drug or the insulin. This is the dark terror study, pre-mixed insulin, which have been predominantly used. And predominantly because it is easy to get, it is available everywhere, but then it has certain problems. Pre-mixed insulin, which we have been using traditionally 10-15 years before, has NPH. NPH is not the same insulin as basal insulin. We have now better insulin. We have now human analogs available, human insulin, then we have analogs, and the work is entirely different. So, but still, the pre-mixed insulin which are used still, they have not been able to refer all the need. The higher is the HbA1c, greater is the fasting blood glucose contribution. And this is what creates trouble in starting, because most of our patients have in the beginning have an impaired glucose tolerance, IGT, or they can have impaired fasting glucose. And these patients with impaired fasting glucose, probably medicine we have only metformin, and metformin fails. The patient can still have fasting sugar 200 plus, cannot be answered by other molecules. So we need basal insulin. These are the glycemic targets which have changed over the period, and right from the 2003 to 2005 and 2008. And then we have now, over most of the landmark history have said that younger is the patient, make it very tight, make it 6.8, 6.2, even 5.8 would be acceptable with the younger patient. Older patient, comorbid condition, it's better to be a little liberal up to 7.5 or 7. This we have seen time and again. If you want to stop the speaker to go from the dash, pull out from his leg below the carpet, it would fall. This is actually what would happen. If you want me to stop, take out my mic away, give me a kick and let this podium go out. This is what would happen. The bottom is taken down and then suddenly the rest of the metabolism becomes very friendly. So you take care of the fasting, fix it first, that would answer. Hence, this is the simple formula to be learned by everybody. Basal insulin provides holistic glycemic control in real world scenario because you start treating and answering the basal insulin one time during the sleep, or you can fix time according to your convenience, patient convenience, maybe morning time, maybe, but make it fixed one time. It's easy. Okay, now we go back to the if the time is more now, I won't be under time. I'll finish quickly, and these are the Indian real world setting in which whether you refer at up to 6 months with initial beginning, the way you give one trick of the basal insulin would be able to handle most of the fasting sugar, and subsequently these patients would require either oral hypoglycemic drug or would also require another bolus insulin. And sorry, it's not responding. Can I do? This is what the easy, best, better efficacy is the glargine 100 over premix insulin. I said premix insulin because it has a combination, it has a 30-70 or 50-50, it has a short acting, it has a long acting, and the pharmacokinetics of both of the insulin are not equal, they cannot be mixed together. But because of the easy way to pick it 2 times by our predecessors, this has been very popular. It has done the job, it has controlled. But then there are the phases of when the patient goes into hypo or patient can go into hypoglycemia. So what is the advancement in the insulin therapy now? Right from the timeline from the NPH, which was the oldest one, is still being used at many, because this is very cheap and this is readily available in the government hospital. We have now the glargine 100, then we have the Datimer, and then we have the glargine 300, and there are certain advantages in using glargine 300, and these are the, what is the less glycemic variability and flexible time of dosing with glargine 300. And this is what's seen in continuous glucose monitoring data. If you do it, then you realize what mistakes we have been doing by giving premix insulin. Even we give twice premix insulin, 30-70, 50-50, depending on the food habit of the individual. We still lack many places when the insulin is not there. Either so patient gets hyper and patient gets hypo. This is what is happening. But the moment you use on my right side, this is where the green is, and then there's the less hyper and hypo, meaning by this is able to be कहीं से शोर आ रहा है. Sorry. So glargine 300 wants low risk of nocturnal oral hypoglycemia, and you look on this side, depending upon the dose of the glargine on both sides, there are the least chances than the traditional 100. Demonstrate lower nocturnal glycemic variability. The glycemic variability is very bad for the vascular endothelial health. The more you have a hyper and hypo or not time in the range, more you have a problem with the endothelial function, the vascular membrane, and also mitochondrial function. Therefore, when you use glargine 300, you have the least variation. The second generation basal insulin over the first generation has a lot of advantage. Flexibility is one. Then it has got a less glycemic variability. It's quite effective. And then obesity, weight gain is much less. And time in range, which is important also issue. So when you compare the second generation basal insulin, this is the bright study, and I'll go directly on the results. Non-inferiority versus IDEC 100, and this is what I've shown into the reduction of A1C. This is no way inferior, this is equally superior. Number two, it has a less hypoglycemia, much lesser than what we have been getting with traditional glargine or NPH insulin. The nocturnal hypoglycemia is much less, and there are better time in range profile with glargine 300 flu basal plus IDEC as 14% higher and 7% lower incidence of hypoglycemia, and then there are the 18% less chances of getting hyperglycemia. So easy and safe titration you can start. The best way to calculate is you start with dose of 1 unit, or you can go 2 unit dose, 1 unit per kg body weight. One can start with 0.5 unit per kg body weight depending upon the injury, but this is very easy to do. And then this is how you titrate along with the 300, 1 dose adaptation, 1 unit dose adaptation. This is inside the study. 2 unit dose adaptation every 3 days, 2 to 4 unit adaptation every week, and when the dose is 3 to 6, then you try to titrate every week. So this is how we start. We can start with 0.5 unit per kg body weight per day, maybe 50 kg patient, maybe 60 kg patient if you are treating, or 70 kg. Then you can start 3 to 4 units to begin with, wait for 2 days, patient not yet controlled, increase another 0.5, then you can increase 1 unit, then you can increase 2 units, and that's how it is easy to calculate. The target fasting sugar should be anything between 80 to 130. 130, why 130? Because still you give chance next few days to titrate. So the practical consideration. You have a lot of questions and the answer you can start. What dose you should start? And general practitioner can start with the 0.2 unit. You can look at the range, and you can fix at the time whether it is day or night, but it's better always fix at one time. Then you can continue the oral antidaptic drugs, as I said in the beginning, whatever you have been using, and titrate insulin from below. And then ultimately you can do up to 0.5 unit per day per kg per day, and that's very easy to do. So the final take-home message, it is still in decimal state. Benefit of OAD beyond 3 is not observed. So anybody is taking more than 3 oral antidiabetic drugs must now start talking and should consider insulin, not only because of the glucose-centric thought, but because of the more than 3 to 4 drugs do not give him response in future. And hardly after a few months he would go back again with the same hyperglycemic state. We have evidence-based benefit of early insulinization. Basal has a better safety, efficacy, adherence, and it is a better quality of life. Second generation basal insulin has advantage over first generation, like provides better safety, better efficacy, and well time in range. And among second generation basal insulin, glargine 300 has slight edge over IDEC. I said slight edge over, this is for the endocrinologist and the diabetologist to consider. Maybe in the beginning you need not go for these minute changes. You can start, you can convince the patient, easy to break the barrier, and the moment patient is convinced, then you can look at these minute changes, whether he should go for one insulin and getting multiple insulin, leave it to the physician, leave it to the endocrinologist, leave it to the diabetologist. They will do the better job. Sometimes they require to do 4 insulin, sometimes they will be adding GLP-RA, which is now the fashion because of the obesity, and probably then you'll be able to answer. Thank you very much. Any question? Query? I'm sorry because of problem this screen which is in front of me, I couldn't control it the way I wanted to do it.
Thank you, Professor K.K. Tripathi, sir, for such a wonderful talk. He has covered almost entire aspect of insulin therapy, how to initiate, how to counsel the patient, and what are the advantages of early initiation of the insulin. Because early insulin initiation should be considered, and patient must be counseled for it, because we have lot of benefits of early insulin initiation. First of all, diet control, which gives you a legacy effect. Number two, basal bolus insulin regimen is the gold standard therapy, and with the use of generation 2 basal insulins, we have less glycemic variability, and as we know, glycemic variability, if it is high, it may lead to several complications which can be avoided by use of newer generation insulins. Basal insulin should be started first, because with a single injection, we can allay the fear of the insulin in the patients, because single prick will allay the fear of insulin, and then we fix the fasting first, and then as per the PPG, postprandial glucose, we need to add the bolus insulin. And this regimen works in a more physiological way than premix insulins. So thank you, Professor Tripathi, for such a wonderful talk. And we invite the audience if they have any question.
Okay, thank you. Organizer saying no question answer.
Thank you so much, Professor Tripathi, sir. I will now request Dr. Agarwal's family, please stay back. Please. Ma'am, aap baithe, please. I will now request President Dr. Sujit Singh sir to please come on stage and honor our speaker for the session. Chairpersons, please join. And I will also request Dr. Agarwal's family, Dr. Sanjeev Agarwal sir, Dr. Vikram Agarwal, Dr. Kavita Agarwal, Dr. Anuradha, to please come on stage and honor our speaker for the oration in memory of Dr. V.K. Agarwal sir. I would again like us all to remember late Professor V.K. Agarwal in all the ways he touched our lives, and thank his family for staying with us, for being here today while we were paying our respect and regards to Professor V.K. Agarwal sahab. I will now request Dr. Sujit Singh to please give away the certificates to our respected chairpersons for the session. Chairpersons, Dr. Anil Shukla sir, Dr. Anil Agarwal, Dr. Atul Mathur sir, Dr. Saurabh Gujarati. Thank you so much everyone. for a wonderful session and for being such a active and interactive audience, and for no questions.